All right, thanks everyone for stepping in. My name's Taylor Brown. I'm a first-year resident at the Beth Israel program in Boston. Today I'll be discussing the importance of trauma-informed care and how we can use it to support both our trainees and also patients with experiences of adversity. My co-presenter is stuck in London and I have lost my voice, so have a little patience. I start all my talks with a content advisory. I won't be discussing anything in no graphic detail, but this is a distressing topic. I don't have any disclosures to share with you all today. But during today's talk, I will define trauma, what it is, and how it presents in the emergency department. We'll talk about the 6 principles of trauma-informed care, and then apply that to both the EM clinical environment as well as the learning environment. So I'll start with the definition of trauma. This is also people's chance to escape if they thought this was a trauma talk about blunt or penetrating trauma. But I use the Substance Abuse and Mental Health Services Administration definition. So I conceptualize trauma as an event, series, or set of circumstances that is experienced as either harmful or life-threatening and has some lasting adverse effect on either some form of well-being. So this presentation is designed with a medium-level interaction. So I'd like you guys to take just a minute to think about a patient case you may have experienced where you think that either pre-existing experiences of trauma affected how the patient presented to care or how their experience in the emergency department went. And after a moment, if you're sitting around someone and you'd like to share that experience with one of your colleagues, just take a minute to discuss how this might have presented. Thank you guys. I know participation at the end of the day is asking a lot. And you've all self-selected to this room, so I will assume that many of you are familiar with the Adverse Childhood Experiences study. But if not, this is the landmark study to make that connection between pre-existing experiences of adversity and health outcomes. So in the 1990s, Kaiser Permanente looked at several potentially traumatic events in early childhood that are listed up here on the slide. And in the original study, they looked at a population that was primarily white, middle class, and insured. But even within that privileged population, they had some groundbreaking findings, including the majority of individuals experience adversity. 54% have at least one ACE. ACEs cluster. And then finally, there's a dose-dependent relationship between the amount of adversity you experience and your health outcomes. For example, adults that experience 4 or more ACEs compared to adults that experience none have a 12 times greater suicide risk. They are 7 times more likely to have alcohol use disorder. They also have increased risk of diabetes, COPD, stroke, and heart disease. And in addition to affecting our patients' health and potentially how they present to the emergency department, experiences of adversity affect how the patients interact with and engage with care. So on the slide, I have illustrated the window of tolerance. And for anyone walking into the emergency department, your experience can certainly bring you outside of the window of tolerance. Inside that gray zone, patients are able to actually engage with healthcare. They maybe understand what you say when you're talking about test results, treatment, or prevention. But when we go outside this window of tolerance, we start exhibiting behaviors that may be considered disruptive or difficult. These can be the patients that are numb, shut down, disconnected, won't talk to you. These can be our difficult patients that are angry and agitated. But what's important to remember is that both of these outside of the window, these are survival mechanisms that an individual learned in a place of adversity, but they seem disruptive when in the clinical setting. Now, how does this present specifically in the ED? This is data, I think, even if you don't know the numbers, you're familiar with. We see a lot of IPV, firearm-related injury, and assault. But what we may not often think about is our patients also have many previous experiences of trauma. The first study by Ted Corbin looked at one of their violence intervention programs. They surveyed participants and found 100% of those individuals had experienced at least one of those adverse childhood events. The second study looked at high utilizers of the emergency department and found that they had a 4 times greater risk of being in that highest risk category, the 4 or more ACEs, 56%. In the final study I've included, because ACEs are very well validated, but they do not in any way capture the breadth of adversity that our patients face. And so this last study looked at individuals that identified as transgender in Ontario and found that 21% of them avoided the emergency department when they had a medical indication for fear of being mistreated. So that was the doom and gloom part. So what do we do? How do we respond to that? So the Substance Abuse and Mental Health Services Administration developed trauma-informed care. It's a harm reduction framework based on these 6 principles I have listed here on the slide: safety, trust and transparency, peer support, collaboration, mutuality, empowerment, voice and choice, and finally, cultural, gender, and historic acknowledgments. So in a longer format, I would have you guys more fully brainstorm, but we'll take a moment just to share some of how this looks practically. When I think about being a trauma-informed physician, I think about applying those 6 principles to care. So for example, safety can be as simple as introducing yourself, your role, being sure to ask a patient's name and pronouns. For trust and transparency, I think about providing anticipatory guidance. What line of questioning are we about to go into? What are we going to be doing in the physical exam? Especially for sounds and sensations as well, reminding patients that ultrasound jelly or gel for the speculum is cold. When I open the speculum, you'll hear a click. I think about peer support, offering patients to have a support person present for any part of the clinical encounter. And during COVID, sometimes this was FaceTiming your family member in. In collaboration and mutuality, I often ask patients if they've ever had an exam or the procedure that I'm about to do, and if so, were there any adjustments I could make? So for the next Think, Pair, Share exercise, I have the 6 principles up on the slide. And so I'd like y'all to just take a minute and think about one of those principles and what that might look like in your own clinical practice. And then if you have someone sitting next to you, turn to them, name that principle you're thinking of and how you might apply that to your practice. Thanks everyone for chatting with some neighbors. So trauma-informed care is a primarily strengths-based approach. So I wanted to take a moment to highlight a few of the areas where trauma-informed care is being integrated into emergency medicine as a specialty. So there have been several educational interventions, mostly that target specific patient populations. My favorite study actually looked at physical and chemical restraint use in the emergency department and found that it significantly decreased after a trauma-informed care educational intervention with staff. And then finally, some of my colleagues that I work with at Harvard Medical School, they're still medical students, have designed a simulation curriculum I think that they're presenting here as well as they did at Cord. Outside of emergency medicine, I've been a part of some work that has validated trauma-informed care competencies at the undergraduate medical education level. And this is really exciting work because it's a step towards actually standardizing this education, starting with our medical students. All right, so now we've talked somewhat about what trauma-informed care is and how it can support our patients. But when we're teaching this, we also need to think about our learners and how we're also creating a trauma-informed learning environment. Second to last, think, pair, share. So at the beginning of the talk, I had you think about a case in which trauma may have affected your patient. And now I want you to go back to that case that you had in your mind and think about if there were trainees, if you had a resident or a medical student with you, how was that case both impacting their learning and maybe impacting them personally? And I'll give you another minute to share with a neighbor. And so I bring that up to say that students and trainees have experiences of adversity statistically, at least, that look very similar to that of our patients. About 51% of students arrive to medical school experiencing at least one adverse childhood event. That's very similar to the national average. And then we all know medical training is at its worst traumatic, at its best, tough. So we're mistreated during medical school. That starts to manifest by the time we get to clinical rotations. Some of us are already experiencing signs of emotional numbing. And then once you get to be a salty resident, you're already experiencing burnout. And no one in this room needs reminding that emergency medicine in particular can be, even pre-pandemic, a violent specialty. We were already prone to very high rates of PTSD or even secondary traumatic stress. So I show this graphic again to say that just as our patients may not be able to engage effectively in their own care, our trainees may not be able to consistently engage in their education if they are outside of, now I've reframed it as the window of learning, but if they are in a hypervigilant or shut down state, they're not learning. And we have no idea, just with our patients, the same way we cannot predict what experiences are going to be challenging for our learners. And this effect is magnified when our learners experience environments that may be hostile. We just had a great talk on microaggressions, as one can imagine. That's another way our trainees can go outside this window of learning. And again, these responses seem maladaptive, but it's our trainees just trying to protect themselves. All right, so now we're moving away from the doom and gloom statistics again to what can we do about it. So we've talked about the portion on your left-hand side of the screen, the content, but how do we create trauma-informed learning environments? So I think when I think about trauma-informed medical education overall and think about that context, I think about the curricular content, who's developing it, how are patient identities or other identities being represented, how's it being delivered, what kind of support do faculty have for delivering this content, and then I think more broadly about the learning environment. What is the on-shift teaching culture like? What kind of resources do students have access to? And similarly, I take the same 6 principles and then apply it when I'm thinking about trauma-informed teaching and learning environments. Introducing yourself, learning your learner's name and their pronouns. No one should just be the medical student on shift. Ensuring proper supervision based on a trainee's level. This varies from institution to institution. You may have off-service rotators, always checking in with them on how they feel comfortable with procedures. for collaboration, debriefing at the end of every shift if you can, because again, it's not always obvious what about a case or a patient presentation was challenging for a student or a resident. And then in terms of cultural, gender, and historic acknowledgement, avoiding stigmatizing terms when we're speaking about patients and colleagues. I think this is especially salient when speaking about particularly stigmatized conditions such as substance use disorder. We hear a lot of language in the emergency department that we know is not the most respectful. And just as an added thing to keep in the back of the mind, we have no idea which of our trainees may have had personal experiences with that as well. All right, final think, pair, share, and this will be a quick one because we're running short on time. I'd like you to think about one of these 6 principles again, and then think about a way that you may bring this to maybe your on-shift learning or on-shift teaching. And so I'll share one example for some of our work at Harvard Medical School with actualizing these trauma-informed learning environments. So after we did work to incorporate into the curriculum trauma-informed clinical skills, we then realized we should have probably done some faculty development with our clinical skills teaching faculty. So we went back and developed a series of online modules to support our clinical skills faculty. So now the clinical skills faculty, it instructs them both in what the students are learning, but then there's also additional modules on precepting, actually trauma-informed approaches to delivering that content and working with students. I'll wrap up my talk with just mentioning this concept of vicarious healing. I think in trauma work, it's very easy to focus on all the negative effects and negative impacts of trauma and adversity. But the response to trauma exists on a spectrum, and many people experience post-traumatic growth. And I think keeping that in mind and growing with patients is what keeps me so invested and interested in this work. All right, we're right at time. So today we talked about how trauma is ubiquitous. It affects everyone. It affects our trainees, our patients, faculty. We introduced trauma-informed care as a harm reduction framework, and then we covered a couple ways in which we can use that to both support our patients through clinical care and our trainees through the learning environment. And I know everyone probably has fun dinners and drinks to get to, but I'll stick around to answer any questions you all might have.